Everyone can see my screen, I hope.
Yes, we can.
So thanks for the introduction. So our focus today is on ACL reconstruction and how instrumentation data monitoring enhances clinical decisions. So I'm going to go over first my disclosures. Nothing that's really relevant to this talk, although I have had funding from TechScan for some of the work that I'm going to be presenting today. So on our agenda, so first I'll start off with some discussions about ACL reconstruction and outcomes, and talk about some point of care applications as it relates to using technology and instrumentation for making healthcare decisions. And then we'll talk about some instrumented assessments of balance and how we've incorporated those into our research and clinical care routines. And then Amelia is going to talk more about loading, movement quality, and squatting assessments to wrap it up. So ACL injuries, they're common. They're common in young adolescent athletes. Females are at higher risk, and they're particularly common in high-level sports. Now, when an ACL is injured, obviously it's a permanent injury. The ACL, at least yet, can't grow back because it's intra-articular. So it's anatomy changing. So there's consequences that are permanent, because to restore normal stability, you have to basically change anatomy and change some tissue structures. So some of those things can have permanent consequences. ACL reconstructions are a common elective treatment in young athletes, especially those who have the goal of returning to high levels of physical activity in sports. There are lots of ACL reconstructions that happen each year, and they seem to be rising. This graphic simply shows the age demographic where ACL reconstructions appear to be rising, which probably matches with the rising rate of ACL tears. And for those of you who are clinicians, you probably get some of these very common questions too. It's when can I get back to my sport as quickly as possible? Is this going to happen to me again? And a question I don't get a lot from the 18 to 21-year-old is what's going to happen in 10 to 20 years down the road? That's what I'm concerned about. I want to know I want to make sure that our patients have the highest likelihood of achieving their goals and being healthy and maintaining active and healthy lifestyles despite them having orthopedic injuries. Sorry, my buttons. And the long-term concerns, obviously, are the likelihood of a hastened process, an accelerated process towards early onset knee joint degeneration. When you think about the incident rate of osteoarthritis in synovial joints in the body, knee is already fairly common, and you see this kind of natural history of degeneration over the lifespan by decade of life. And unfortunately, if you superimpose a bad knee injury like an ACL reconstruction early on in life, that dramatically accelerates the process. Osteoarthritis is incurable; it's permanent. So the best way to avoid it is to help prevent it, and the best way to prevent it is to have precise research-grade measurements that we can make decisions from and treat our patients. So awareness is key. This is something I've said for actually decades now. Awareness is key. I've had mentors and friends that have said you can't treat a fever without taking a temperature, and your treatment is only as good as your thermometer. So you have to have good research grade precision in your assessment, good technique and training, and check early, check often, especially with injuries and diseases that have early onset problems. This is the assessment program. So we'll talk about kind of some of the programs that we have, or this program that we developed at University of Virginia. This was my prior institution before I went to UNC, where we developed a program called the Lower Extremity Assessment Protocol, and it's a program that we have implemented to merge as close as we could with the point of care at the times when patients were already being seen by their treating surgeons. And we would provide these highly precise evaluations of muscle strength, jumping, balance, jump distance, and then patient-reported outcomes. This QR code, if you hold up your phone either now or on the recording, you can see our full video showing exactly what we do. So yeah, feel free to take a look at that in your time and just kind of see what our story is and kind of how we have done things at the University of Virginia. So I think the key here to having a sustainable program, especially in incorporating research with clinical care or providing research grade data at the point of care, is providing a takeaway. I think that I struggled for years to get this program off the ground. It really didn't accelerate until we started handing data back to their rightful owners, back to the people who were providing the data to us. And that's where we started to get real buy-in, and the data were being used well. This is an example of the report that we would give back to patients who are being seen at, and our routine doesn't need to be your routine, but our routine was at 4 months, 6 months, 8 months, and then annually thereafter. Obviously, we had a lot more people showing up for the 4 and 6 months after they were discharged. It was hard to get them to come back. And if you think about, so how this is just an example of a report from a healthy person. So everything's reported on a red light, yellow light, green light in our case, where symmetry is the basis for green light, 90% or higher, and then red light is anything lower than 85%. It wasn't a clearance. It was just a hey, look at me, pay attention to me, or pay attention to this metric when you have a red or a yellow light. And we presented those in various phases: isokinetic strength, isometric strength. We did a fatigue index. We did landing error scoring system for movement quality. We did patient-reported outcomes, a bunch of them. We just reported 2 of them there that were focused on the knee. We looked at symmetry in jumping, and then single leg balance. So the kind of this output report becomes a bit habitual and familiar to our end users as we're showing them. So symmetry. I want to take a second to talk about symmetry, and this will lead really well into the talk that Amelia is going to give here at the second half of this of this hour. I think for one, I don't know if you all have a love-hate relationship with symmetry. Symmetry, especially when using symmetry and the assumption that 100% symmetry, perfect side to side symmetry, is a indicator of good musculoskeletal health. It relies on the fact that when you're dealing with someone that has a unilateral injury, that the contralateral side is stable. And this is kind of what we've seen. I guess this video isn't going to work. But basically, these are each data points showing a plot showing the uninvolved versus the involved side strength. And each of these lines represents where that relationship would sit on symmetry, from 100% at the top to 90, 80, 70, 60, 50, 40% here at the bottom, symmetry showing deficits. And when you track people over time, you can see that the patient journey in maintaining symmetry depends on, or kind of relies, or improving their symmetry relies on them improving strength just in this vertical axis. But what we see oftentimes is that symmetry is either accentuated or reduced by increasing strength of the contralateral limb or the ACLR limb. And this is an interesting case where symmetry kind of baffled us a little bit. So this was a young soccer athlete that we treated, probably over a decade ago. He had a left-sided ACL injury, saw us at around in his postoperative period. You can see left versus right. He was fairly asymmetric. And then as he was recovering, we tested him 4 or 5 times over the course of the following months. And he kept on getting stronger and stronger on his reconstructed side, but his symmetry metrics weren't getting any better, because his contralateral side kept on strengthening more and more, which to me kind of indicated some sort of a weight shifting or avoidance pattern, or some sort of difference in movement patterns that Amelia is going to really talk about. So the physicians in this case decided to release him once his reconstructed side got back to his pre-injury strength levels. But unfortunately, he tore his contralateral side a few weeks later, and kind of had a bilateral injury. So again, a love-hate relationship with symmetry. I think no matter what you do or what metric you use, I think it's really good, in my opinion, my experience, to match data and outcomes collections at time points where the patient is already in your care. When patients are in your PT clinic, in your orthopedic offices, we've conducted over 1,300 tests on patients in our lab, which is good because we have really good control over it. It's a much more quote sterile environment and easy to control, but it's inconvenient for patients and hard to get to. Again, weigh those strengths and weaknesses each, and then again, whether or not you're going to use your data for healthcare decisions on the sideline. Again, the accessibility remains important. These tests that we developed for following ACL patients were made for kind of the typical ACL reconstruction patient who's a young athlete. We see a lot of folks, in a broad spectrum of ages, 30s, 40s, 50s, who elect for ACL reconstructions, who want to remain physically active. The tests that we're presenting to you are really focused on the younger athlete and the person who wants to get back to a higher level sport. One thing that we've kind of struggled with a little bit is whether or not some of these metrics are important for athletes or patients who are going back to other forms of physical activity, whether we need to have a 50-some-year-old person jumping, and if that's going to give us information that's useful for our diagnosis and treatment. The patient information video, the thing I showed you before, is so important, just to have some sort of element of what they're going to be doing, so there's no surprises. I think novelty in task is a limiting factor that can affect precision in your measurements. So not only practicing but giving expectations through preliminary information is essential. And if your patients are young and adolescent, it's sometimes difficult to engage them through the process. And I've got 3 adolescent children, and then they have a hard time following directions, let alone on things that I've told them 100 times, let alone something they're hearing for the first time. So these videos and engagement with adolescents and parents definitely have helped us over the years. And then safeguards, where you're doing these tests or what you're actually doing. We have implemented several safeguards, whatever works for you, but protecting the patient, whether it's for research or clinical care. We always do isolated muscle testing before jumping, because if a patient has profound weakness, like more than 80% asymmetries or 75% asymmetries, we're not doing jumping. That's not going to help us learn anything more about that patient's condition, because it's exposing them to risk that I feel is unnecessary. And I'm only doing jumping or risky maneuvers if they performed it before. I don't want to do any novel task for the first time that's going to present risk to a patient. Again, it's my opinion, and you can put safeguards in that are good for you all. And again, the report and interpretation. These tests are kind of called return to sport tests or return to activity tests, but I think they should be considered in combination with many other factors, including other readiness metrics, fear, anxiety, sport-specific observations, and a progression towards sports. One thing I do want to chat about a little bit is really the value of information, and not only information but repeated information. This is an abstract that we're going to present at AOSSM next month, where we basically proved that patients who were seen multiple times over the course of their recovery after ACL reconstruction with instrumented measures are doing better at the terminal endpoint of their assessments. They're feeling better through their patient-reported outcomes, and their muscle strength is better, because they know they know what they have to do, because they have the information before it's too late. So today we're going to talk about focus on among all these tests, instrumented balance information. And again, just a very quick review about some of the metrics that we discussed. This is an example of a force plate, and the 2 force data streams that come from that, both in the X and Y axes, medial, lateral, anterior, posterior axis, and the stabilogram that results from that. And these stabilograms, which are essentially stochastic tracings of the body's center of pressure during various balance tasks or perturbed tasks, single leg, double leg, tandem stance, eyes open, eyes closed. But basically, as this stabilogram, these stabilogram features change, it's an indicator of progressively worsening or improving postural control and balance. You can see how this very small area of a stabilogram is indicative of better postural control than this more random and larger deviations. And those deviations can be expressed as a kind of a distance from medial to lateral, a distance from anterior to posterior, a total distance traveled, like the path of this line, or kind of a confidence interval, an area, a confidence eclipse that encompasses most of these data elements. Again, the larger the area, the larger the excursions of the center of pressure and the poorer the balance. So we actually were interested in doing a variety of tests. We had used two instruments, this force plate and a pressure mat. This is the AccuSway, and this is the mobile mat from TechScan. And we're interested in kind of determining whether force sensing versus pressure sensing had a difference in these output metrics. So we measured 30 healthy young adults. We did eyes open and eyes closed for single leg balance. And we calculated the percent change from the eyes open to eyes closed. And if you look at this graphic, this is what's interesting to me. It was these two, they're both measuring a center of force or center of pressure, respectively, which is essentially the point within your base of support that your ground reaction force is acting. And that center of force moves around, the center of pressure moves around as you're balancing it. We saw in the prior slide. What we found is that when we plotted the two data streams, the medial lateral excursions, the anterior posterior excursions, the path length, the distance traveled, and that area eclipse, they're all fairly highly correlated, and they have really good agreement through the ICCs. But the best agreement was when we looked at the modulation, the change between two states of balance. And where that became relevant was when we looked at, these are Bland-Altman plots. And what was interesting to me is that all of these in unit of measure metrics were all on demonstrated fairly decent agreement between the two measures. But one was consistently measuring at a lower value, lower magnitude than the other. So there actually were the shortcomings in agreement were primarily because they were two different instruments measuring a similar feature of balance in two separate ways. So regardless of the agreement of the two data streams, when we looked at how they were changing from eyes open to eyes closed, the instrument didn't matter. So we went with the instrument that we really liked, because when we're comparing one, kind of a modulation, the instrument was really really instrument agnostic. And I think one of the other interesting things here is I hear a lot of well, I'm at a high school, or I'm in a clinic that we can't afford instrumented measures. There are actually free, low cost, no cost, and accessible things. These are some examples of them. First and foremost, your smartphone is actually a fairly high resolution camera and a fairly high resolution video capture device that you can set the frame rate to a fairly high level, like 240 frames per second is pretty precise when it comes to looking at subtle features of movement. But these are some other programs that are free and openly available to measure various aspects of kinematics or balance. But the one thing to remember is, regardless of what you're using or what you're doing, you're using this data to make an important healthcare decision, whatever that is: tracking progress, returning to sports, going from identifying risk for injury or re-injury. So it really is important to utilize expert and current techniques and precise data. And then, instrumented evaluations are super important, because you want to be able to look at, or to be able to detect very subtle changes and not miss something that could be absorbed within a measurement error. At the very least, I think smartphones and cameras are fairly ubiquitous. So recording with videography or digital imaging is super helpful. One free and cheap scoring system to utilize, if you don't know it already, is called a balance error scoring system. It's actually really well presented in Physiopedia. .com if you want more information. It's easy, it's cheap. It basically assigns a single error for a postural deviation that's indicative of worsening balance. It's kind of like a golf score. The higher score, the worse you are. More errors that you're committing. And here's a listing of the errors. You need to do 6 20-second trials with eyes closed in various stances on firm and foam surfaces. Some of the warnings with tests like this are, real-time scoring becomes challenging. It was developed to be scored in real time as the test is happening. With sometimes you miss things. I've always video recorded these tests when using them in research, and it's really easy to do. And obviously doing it with trained examiners. There are prior research showing that patients with ACL tears can detect a difference between a person with and without an ACL tear, but the margin is very small, just a 2-error difference when looking at the total score. When you look at one-legged stance, which is one of these tests here on foam, it's probably the most challenging of these tests for a person with a knee injury. That's where the biggest margin was in this study. It was nearly 4 errors. So we actually looked at this to see if, because manual scoring takes a heck of a long time and there's a whole lot of error. If you just, I do this with my biomechanics class each year where you kind of have people score in real time, and it's amazing how sloppy it can get. So automation is key. We actually tested this automatic error detection software that came with our pressure mat from TechScam, and compared manual trained human frame by frame with timestamps, human recorded errors from these video recorded sets with this automated error detection software. And this is the plottings of time versus each patient. The blue X's are the computer detected errors, and the red dots are the human detected errors. We actually I'm going to zoom in on these a little bit. If you look at these, so again, the red is human detected error, and the blue is computer detected error. So this is an example of bilateral stance on a foam surface. So you can see that there was very few errors, as you would expect with bilateral stance detected from videography, but the computer was detecting a lot more perturbation. Same thing. So they were really measuring 2 different constructs of balance, and it's the same test, it's the same outcomes, but very different measurement techniques. The interesting thing that we learned from this was that, and these are the results, both with straight. We evaluate straight knee balance, a single leg balance with the knee bent to about 30 degrees, and then single leg squat. With this automated scoring system. And what we found, both with automated scoring for best tests and with center of pressure excursions using an instrumented pressure mat, the only way that we could detect the difference between a person with and without an ACL tear was when the knee was bent to 30 degrees. It's probably because it's in a loose pack position, and this is a position where you're really engaging the quadriceps and using it in a way that evokes the modalities of postural control. We did not find any differences with repeated studies with straight knee balance for ACL patients. So in summary, ACL recovery is complex. The decisions for progress and healthcare decisions should be based on precise data. Should be done as best you can at the point of care by independent examiners, so you're not so you're kind of avoiding training to the test. And then just some balance assessment reminders. Technique is important. Instrument whenever you can. Video at minimum, and then automation, if available, if possible. All right, that's all I've got. Thank you so much for your time, and I'll look forward to the next talk.
All right. Let's see.
You good?
Yeah, I'm just making sure.
One.
Yeah. Let's see. I'm not quite seeing it.
Lower left. Share screen, lower left. if you click entire screen and then share, you can load it right from there.
So sorry.
Don't worry about it. It's all good. No need to apologize. It's all technology.
I know. And unfortunately, is not my strong suit.
What are you looking at?
It's saying that it is not allowing me. It says there's a security block on it.
Are you on Mac?
Yes, I am.
Okay. Click System Preferences.
Okay.
Did you switch computers from the
I
last?
did.
Okay, gotcha. All right. Hit System Preferences. No problem. Yes. Then click Security and Privacy.
Yes.
Then go down to Screen Recording.
Yes.
And then unlock and click Google Chrome. And then you're going to have to restart. So you'll just leave the room and come right back in. It'll probably say you have to restart Google. Yeah. That's all right. And then just come right back in.
Cool. Okay, gotcha. All right. I will hop right back. So sorry. I will be right back.
Okay. Perfect. Joe, I was going to ask you to come back on because we do have a question. So So Ben asked, what is the best exercise suggestion for more kick power on a mildly deficient left ACL for soccer?
Oh goodness, that's really specific.
It's a loaded question.
I'm more on the assessment side than on the rehabilitation side. But I do know that there are quite a bit of good aside from the specific exercise that you will do. One thing I would like to raise to this group is the notion that when you are encountering patients that are having very resistant quadriceps weakness, they're doing therapy, they're engaging in exercises, and they're just not getting any better. The only way that you can detect that is with serial measurements. All right, whether it's balance, postural control, strength, performance, patient-reported outcomes, you have to be able to see progress and change. We're only using measurement techniques that are precise enough so that they can detect very subtle changes. So if you're doing something, these measurements should change. So think about how whatever exercise you're doing, and I'm not trying to like dodge your question. I really just don't know any specific exercises for that space, but I want to encourage you, if you are implementing exercises that are well thought out and justified in your patients, do these outcome metrics to make sure that you're showcasing what the changes that you are providing to your clients and patients. Otherwise, and then you can share that information with the rest of us about what you're finding is working, what you're finding is not working, which are both shareable, equally shareable and pieces of information. Yeah,
I agree. I think, again, establishing the baseline, doing the change, the exercise, and then measuring it after. I mean, it's basically, that's what that pretty much you're using the technology to do that.
That's right.
Perfect. See that? Perfect timing. One question, you get back on, bang, we're ready to go.
All right. How about now?
We're there.
Hey,
Amelia. Good
Great.
stuff.
Awesome. And if you can't see anything, please stop me and let me know. Cool. Hi, everyone. Sorry about that. Not great technology, but we made it. We made it here. All right. So I'm going to give a quick little talk, part 2 of instrumentation and data monitoring and how you can use these things with enhancing clinical decisions. So following an ACL reconstruction, a lot of individuals really suffer from poor physical and psychological readiness. And this can be from muscular weakness, some kinesiophobia, just fear of re-injury. And these things can really alter these individuals' movement patterns. So we are very functional beings. So we really have a lot of functional movement that we engage in day to day. So a previous study found, looking at walking, they looked at individuals who had torn their ACL and had it reconstructed, and then they had healthy match controls. And they found, like, whenever you have an ACL reconstruction, that those individuals offloaded their ACLR limb up to 22% in their daily loading activity, which can really, really add up over time, and can potentially be a problem later in life. And whenever you're looking at more functional, or not functional, but more dynamic and more high-speed tasks, such as a stop jump, just kind of like a jump landing activity, and as well as a squatting task, this group found that, oh, there we go. Perfect. This group found that, sorry, my screen moved, that these individuals who had torn their ACL offloaded their surgical limb compared to their non-surgical limb during both of these activities. So a way to kind of measure this, these offloadings, is similar to how Joe had talked about the limb symmetry index. And so what that is you take the ACLR limb, the metrics that you get from that leg, and divide that by the contralateral limb, or their non-surgical limb. And you can multiply that by 100% to get a percentage. And just for reference, 100% limb symmetry index is indicative of equal contributions from both the ACLR limb and the contralateral limb. So this is kind of what we're trying to get these patients back to. There are some clinically acceptable thresholds, kind of like the red, yellow, and green lights that Joe was talking about. And right now, our clinically acceptable threshold for return to play guidance is 90% or greater. And so some consequences of poor movement quality, this can really put individuals in risky biomechanical positions with some knee valgus that can put them in an increased risk of re-injury. And some people call this kind of like a young patient with an old knee. So you have this ligamentous injury, and you have kind of a cascade of events that kind of happen following this injury, being pain, inflammation, peripheral deafferentation, laxity, and all these things can really disrupt an individual's sensory feedback. And this feedback that they're getting from their body, from the environment, can really alter their motor patterns. And this can really lead to this negative feedback loop over time. And without intervention from rehabilitation specialists or clinicians, this can definitely be a problem for people long term. So there has been a study conducted recently in 2019, and this group looked at a sit-stand task and a squatting task in 3 different scenarios, being a natural stance. So just they told these individuals to do a sit-to-stand and a squatting task just how they would naturally. And then they had them go through a instructed sit-to-stand and squatting task, and then they had some like visual feedback during these tasks. And as you can see with the ACLR group, in the control, there's definitely differences in how these individuals load their limbs during these different tasks. And as you can see, as these individuals get more and more feedback from the clinicians, they kind of converged more towards the control and towards that 1 or 100% symmetry, which is what we want them to get back to. But if you don't intervene, this natural path that these individuals take, or this natural stance, is without any type of intervention, could potentially lead to putting individuals in these risky biomechanical positions. And over time, poor loading in the knee could definitely lead to some early onset osteoarthritis. And it has been observed that there has been some precursors of OA in individuals who have torn their ACL knee as early as a year post-surgery and post-injury. So definitely something to take into consideration. So I'm interested in bilateral squats, and I think that they're a great model to use when looking at limb loading in individuals who have torn their ACL. And I think this because squatting tasks can be performed very early in in the recovery phase. This task is very cyclical. It's safe, it's easy, it's cheap to do, and individuals do squatting tasks in their activities of daily living. So getting up and down from a chair, from a sofa, on the bed, and people need to be able to do this type of task. It's also, like I said, modifiable with feedback, being verbal, visual, tactile, very modifiable with different types of instruction. And it's also adaptable to meet the patient's demands. So as somebody becomes very proficient with their technique and everything during a just general body weight squat, you can weight them, putting some load on their back, or you can also progress them to doing more unilateral work. So you can definitely make the difficulty of the task more challenging as the patient progresses through rehab. So during rehabilitation, like I said, individuals really, rehabilitation specialists really like to use bodyweight squats. This is a strengthening technique used to load the knee and the surrounding joints just to kind of get the knee working and kind of back into its normal rhythm. And also it's a way for rehabilitation specialists to really look at the patient's technique and see any potential movement compensations and really try to address those early in rehabilitation. One common compensation that individuals present with is a kind of termed offloading. And this is a shift in body weight away from the ACLR knee. And this can go to the non-surgical knee or even to adjacent joints like the hip. So this decrease of load on the ACLR knee can be due to several different things, such as the patient might be experiencing pain, some muscle weakness, decreased range of motion. And so there's different reasonings of why individuals might be doing this. So for my assessment that I'm looking at, I am really like the double leg squat, as I mentioned, and we use the TechScan SB mat. We collect our data at 60 hertz, and we have these individuals do 3 sets of 3 repetitions to a set cadence of 40 beats per minute using this metronome app. And as the TechScan software really produces a really nice graph of the force time curves per limb. So just a little bit of reference here, you can kind of see the foot outlines in the sections to the left of the screen, and then you can see that force time graphed on the right-hand side, where time is on the x-axis and force is on the y-axis. And the blue line is going to be all of the force that is outputted from the left foot, and the red line is going to be all of the force that is given from the right foot. And that green line up there is just a summation of both the left and the right foot to give a total force from the entire body. So this is what it kind of looks like in action. There we go. So you can see our patient here is standing on the mat. They're doing some squats. And as they're kind of going up and down, you can see how they're shifting their weight a little bit heavier on the left foot. So that left line, or the blue line, is a little bit higher than the right foot. So you can kind of see how, or what I'm seeing of how individuals are shifting their weight to one foot or the other. So for our data processing, we are trying to figure out how to analyze all of this data. So I have created a few squat metrics. First that I'm going to talk about is peak force. So this is going to be 2 separate metrics, one for each foot. So this is going to be in newtons. And just as an example, we're going to pretend like for this force time graph, you can see on the right that the left limb is going to be the ACLR limb. So in order to get the peak force of the ACLR limb, we're going to take the peak force from each of the trials and average that across the 3 sets. And then we'll do the same thing to get the peak force for the right limb. We'll take the max force from each trial and then average that across the 3 sets. And so the second one that I'm going to talk about is our average force distribution. And again, this is going to be two separate metrics or two numbers that we derive from this metric. This is going to be in a percentage. So again, back to our example, we have our left limb is going to be our ACLR limb. And so in order to determine the average force distribution of the ACLR limb is going to be, we're going to take the left limb, all of the data from the left limb or the blue line, and divide that by the left limb plus the right limb. And then we'll do the same thing for the average force distribution of the contralateral limb and just take the right limb divided by the left plus the right limb. And just for a little bit of reference, a 50% or 0.5 metric from, or 0.5 value from this metric is indicative of equal force contributions from both the ACLR limb and the contralateral limb. And then again, our last metric is going to be limb symmetry index, and that's going to be in a percent again. And so for our left limb, being the ACLR limb, our LSI value is going to be the left limb divided by the right limb times 100%, with 1 or 100% indicative of equal contributions from both the left and the right limb. And that's kind of what the goal would be, is to get these individuals back to 100% LSI values. So we have some preliminary findings that I wanted to share with you guys. I did present this at the National Athletic Training Association conference in 2021, and we had a cohort of 58 patients, and all of them were about 6.4 months post-surgery. And we had them do this squatting task. And what we found was that there was a low to moderate loading asymmetries between the peak loading metric and the average loading distribution, where the ACLR limb metrics were lower than the contralateral limb. And you can see the differences here in the graphs. And this was all conducted with just paired samples t-tests. And so my overarching goal for this research is to really aid and enhance clinical decision-making with all of our stakeholders. So here at UVA, we have our UVA Health Group, and that's going to be the physicians group with all of our sports medicine staff and physical therapists. We have all of our athletic trainers. We have our orthopedic department with all of our surgeons. And then the lab that I'm a part of is the exercise and sports injury lab. And so trying to bring all of these stakeholders together to really give our patients the best care that we can. And I'm trying to really highlight that squat performance is really important. Being able to, again, like I said, have an easy, safe, cheap metric to use early in rehabilitation to really inform decision making for patients throughout their rehabilitation phases. And just to give kind of a scientific justification for really using this type of functional movement assessment during a return to play assessment for clinical practice. Thank you very much.
Awesome. Well, you flew through that. Really good.
Yeah.
Great. Great job. Really. Okay. So if Joe even wants to pop back on the stage as well. Perfect. We had Sonia asked, do you need to account or calibrate for the dominant side? Is that even detectable in people before injury?
Yeah, so we collect that data. We haven't looked at it really closely just yet, but we do have that data, and something that we've kind of talked about, kind of exploring a little bit further in the near future.
Okay.
Yeah, it was sorry that I was switching my earbuds. The question was about limb dominance and ACL recovery.
Mm-hmm.
Yeah, but that's another interesting dilemma with using symmetry as an outcome metric. and assuming that 100% symmetry is an indicator of kind of a satisfactory or good outcome, like the target. One thing that we have found through research is that symmetry is less safe of an assumption the more specialized the athlete becomes in their sport. So take the American football punter, the kicker. That person is going to be inherently asymmetric as a function of their training and their exposure to day-to-day stresses required to be good at kicking. Same thing with soccer players or football players, who are wings versus middle players. It makes sense that a person's athletic exposures will have an influence on their muscle strength patterns. The issue with that is, and I think it's a good idea to identify dominance when limb dominance when performing these evaluations, because the assumption for limb dominance is that the dominant limb is stronger. Mm-hmm. So, for example, if you tear the ACL, the dominant limb, and that one should be stronger already, and as you're rehabilitating that dominant ACL reconstructed limb, and you get to 80% or 90% or 95% of the contralateral limb, you're releasing that player when they should be all the way, asymmetric, because that's what's necessary for their sport. So that kind of highlights two things that we've struggled with a lot. Number one is the ability to leverage screening or baseline scans, so like folks who are concussion folks are doing. They're screening and baseline testing everybody to provide a stable base, because they know that neurocognitive outcomes change over time. So they reestablish that every single year of sports participation, and they establish that before an injury happens, so they can use that as the metric to return safely to sports. The issue with that is resources, obviously, but I think we've with this question, we've identified more problems than solutions. But I do think the question of whoever asked that is very important to consider when you are evaluating symmetry. Is consider which limb that the athlete identifies as their stronger or dominant limb, and weigh that in your return to sport decision making. The second thing I'm going to recommend is looking not only at the symmetry, the percentage metrics on whatever you're looking at, whether it's balance or strength or hopping distance. Look at the raw values and see how each side is changing. See what's driving that symmetry metric, whether it's the reconstructed side getting stronger or whether it's the contralateral side getting weaker. We've seen both things happening in our experiences at UVA. Thank you for the question. It's a really important point.
That's awesome. So Dr. Pearl says, how does squat power translate to kick power? I ski double black diamond, have decent squat strength, but left ACL deficiency with right dominant foot, very weak kick strength. I don't know. Maybe you can decipher that question a little bit. Do you see it there?
It's interesting. Amelia is, I see it. Amelia is looking into kind of the ability to translate a low energy, low impact squat maneuver with a more dynamic, power generating maneuver. And I think that question is currently unanswered. But I think the assumption we're making is that symmetry in low impact squatting is if measured early on in a rehabilitation process and serially, is a good indicator of potential compensations to avoid using an injured or weak limb. That's really the purpose of doing this, is to help somebody so when you're telling somebody, and this is where I think symmetry is a good thing, where I this is my love relationship with symmetry, is when you're telling somebody, you're instructing them to do a symmetric task. So when Amelia tells someone to do a squat, she's telling them to stand in the middle of this platform and squat down like you're sitting down in a chair. It's supposed to be a symmetric task. And if you can't do that, even though you're being told to do that, then that's a problem. And if you measure that time after time, even though you're doing we've seen this so much where you're doing unilateral exercises on the ACL reconstructed limb, as expected, you're seeing offloading on the ACL reconstructed limb at 4 months after the surgery. They're getting stronger, but they're still offloading. So how does that differentiate what you do with that patient? Do you continue to put them on the knee extension machine? Do you continue to do leg press, or do you do more technique training, more motor control training? So I think no matter what the answer is, I think you've learned something unique that's helpful to your patient and your treatment decision making.
I mean, do you think that 100% symmetry is actually achievable? I mean,
that's a really good question, and
no one asked that, but.
No, that's a really good question. I'm actually glad you asked that, because when we first started this program and we started giving these, quote, bad results, these red lights across the board. I mean, I had parents and families and coaches and doctors, like, your equipment's wrong. Your equipment's broken. What's going on? So we actually we answered that with let's answer that question. Let's figure that out. So that in that slide that I showed about the two LEAP reports, the two outcomes reports, so when we do measure healthy participants, they tend to be on average symmetric. So 99 to 101% symmetric.
Oh, wow.
But what I said before was true. When a healthy young person is a recreational athlete, symmetry is a safe assumption. When they're a specialized athlete, depending on what their sport is and what their role is in that sport, I'd be careful and learn more about that patient to determine what dominance and how dominance impacts that person and their care.
So then what would be considered symmetrical for that individual might not be symmetrical for someone who's, not a specialized athlete. Right. So
and that's why,
per athlete.
Totally.
That's interesting. Yeah, I like that.